Hi everyone, let's talk about Bera, which is brainstem evoked response audiometry. So you are testing the brainstem evoked, it is in response to a certain stimulus. Brainstem evoked response audiometry. We are doing an audiometry. So it's also called auditory brainstem response. So we are giving a stimulus, click stimulus. We are giving click stimulus, and then we are seeing recording what is happening in the entire auditory pathway. Okay, starting from eighth nerve, cochlear nucleus, olivary nucleus, olivary complex, superior olivary complex, lateral lemniscus, inferior colliculus, E. colima, medial geniculate body, and the auditory cortex. So entire auditory, we are going to test the entire auditory pathway by Bera, and that's why it is considered the best audiometric test, though it is time taking and costly also, but it is considered the final diagnostic test comparable to MRI. So if you are having any doubt with CT, you go for MRI. So if you have any doubt with autoacoustic emissions or acoustic reflex, if you're having a doubt, those are basically considered as screening tools, but this is basically a kind of diagnostic tool. It is a diagnostic tool, so you confirm the diagnosis with the Bera, okay, or ABR. So basically, Bera, what is it? We are giving a click stimulus. And we are recording the electrode. We are placing the electrodes on the vertex, and we are recording the electrical activity from this vertex. So this is basically an objective test. It's a non-invasive test. Electrocochleography, what did we do? We placed an electrode through the tympanic membrane and placed it on the cochlea. Okay, so that was an invasive test. So this is a non-invasive test. So these are the very great positive points about this test. It is an objective test. You don't require the response from the patient. Conscious response from the patient, and also it is a non-invasive test. So these two make the test very preferable. And what does it do? As I said, it tests the electrical activity in the auditory pathway. Electrical activity in the entire auditory pathway. Electrocochleography was measuring what? It was measuring the action potential of the distal part of the auditory nerve, and the summating potential, that is the electrical activity of all the electrical activity of the cochlea and cochlear microphonics, that is hair cells. So, but this is measuring the entire auditory pathway. So this is the advantage in response to sound stimulus. So we give a sound stimulus, and then we pick up these waves. Okay, so when we give a click stimulus, when you give several click stimulus and we place electrodes on the vertex, we get various electrical potentials which are generated. Okay, so this is the auditory pathway. We will talk about it in detail. So we are placing we are giving the sound stimulus, and we are picking up the electrical potentials that are generated by the various parts of your auditory pathway. Okay, so what is Bera waves? Bera waves, in a normal person, 7 waves are produced in the first 10 milliseconds. So 7 waves are produced. 1, 2, 3, 4, 5, 6, 7. These 7 waves are produced in the first 10 milliseconds. So in the first 10 milliseconds, they produce 7 waves, and we study these 7 waves. Okay, on the x-axis is the latency, that is after giving the click stimulus, when is the first wave coming, that is the latency in milliseconds. Suppose this is 2 milliseconds, the first wave has come 2 milliseconds after giving the click stimulus, so that is the latency of the first wave. Suppose it should come at 2 milliseconds, but it is coming at 3 milliseconds, so the latency has increased. So on the x-axis, we measure the latency in milliseconds, and on the y-axis, we measure the amplitude. Suppose the amplitude should come to, like, say 5 microvolts. It doesn't come to 5, or it is increasing beyond that. So all this will give an idea about the various diseases in the auditory pathway. The entire auditory pathway can be checked by doing Bera. Okay. These pathways, they come from the different areas of the auditory pathway. So the waves are studied for absolute latency, that is how many milliseconds after the click stimulus we are getting it. Interwave latency, what is the difference between first wave and the fifth wave. So this is the interwave latency. The first wave to third wave, what is the interwave latency? It is 2 milliseconds. Third wave to fifth wave, what is the interwave latency, it is 2 milliseconds. First to fifth, it is 4 milliseconds. So that is how we check. First to third is 2 milliseconds, third to fifth is 2 milliseconds. Obviously first to fifth will be 2 plus 2, that is 4 milliseconds. So this is the interwave latency. We are trying to measure the interwave latency, and also we measure the interaural latency. Suppose a wave 5 is coming at so and so milliseconds, and say 2 milliseconds, and in the right ear, which is the normal ear, and in the left ear, which is having the disease, it is coming at 2.2 milliseconds. So this is the interaural latency also we can check, and also the amplitude. Okay, wave 5 is given more importance in Bera because it is the most prominent, easily identifiable. So wave 5 is given the most importance in Bera. Okay, wave 5 is given the most importance in Bera. So where do these waves come from? So we remember basically the mnemonic for the auditory pathway: 8th nerve, cochlear nucleus, 8th nerve, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and auditory cortex. So we have E. colima: 8th nerve, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and auditory cortex. Okay, these are the E. colima pathway that we remember, right? So we have to remember that you write down this E. colima on the left side, and then there is no consensus. There is no clear consensus where this comes. Some textbooks say that medial geniculate body gives rise to 6th and auditory cortex gives rise to 7th, but we basically follow the textbook, and the textbook says that medial geniculate body and auditory cortex do not give rise to any waves. Okay, and the 8th nerve distal part is giving rise to wave 1, and the proximal part is giving rise to wave 2. So the 8th nerve is giving rise to two waves, wave 1 and wave 2. In the 8th nerve, the distal part is giving rise to wave 1, and the proximal part is giving rise to wave 2. And then you get cochlear nucleus, which is coming second, is giving wave 3. Olivary complex is giving wave 4. Lateral lemniscus is giving wave 5. Inferior colliculus is giving wave 5, wave 6, and wave 7. Okay, this is how you can remember it. Okay, this is not so important from the. If you can write it in the book in the exam, this is very good. But this will be asked in NEET PG, so we have to be you have to learn it. Just write down the E. colima pathway on the left side. On the right side, for the 8th nerve, the two waves are coming, wave 1 and wave 2, and then you write 3, wave 4, wave 5. Inferior colliculus is giving rise to wave 6 and wave 7. Okay, the same thing I have again put it here. So auditory nerve, this is the cochlea. The proximal part is giving rise to wave 1, and the distal part is giving rise to wave 2. Cochlear nucleus is giving rise to wave 3. Okay, and then the olivary complex is giving rise to wave 4. Lateral lemniscus is giving rise to wave 5. Inferior colliculus is giving rise to wave 6 and wave 7. Okay, wave 6 and wave 7. Okay, this is the site of origin of the Bera waves. How do you interpret Bera? Okay, how do you interpret Bera? The interpretation of Bera is again important from the NEET PG point of view. It is very good to be having a knowledge about how do you interpret Bera. So the first one, what is the scenario? Wave 1 is delayed. The wave 1 is coming late. It is not coming at the right time. It is not, the wave 1 is coming here at 2 milliseconds. Sorry, 2 milliseconds. It is not coming at 2 milliseconds. It is coming at 3 milliseconds, say for example. But the interpeak latency of wave 1 and wave 5 is normal. That is, for the first wave is coming a bit late, but the distance between the rest of the waves are coming at normal. That means the rest of the waves are coming normal. The interpeak latency between wave 1 and wave 5 is normal, that is 4 milliseconds. So the rest of the pathway is normal, but the initial part there is a problem. That is, the defect is before wave 1. The defect is before wave 1. Where does the wave 1 come from? Wave is coming from the distal part of the cochlear nerve. So the disease has to be in the cochlea or the middle ear, or it is something like conductive pathology. One of the examples is conductive deafness. So the wave 1 is also coming, but it is getting delayed. It is increased latency. So the disease has to be before wave 1, that is wave before the distal part of the auditory nerve, that is in the cochlea or the middle ear. Okay. So that is the first scenario. Second thing, what is happening? Wave 1 is present. Wave 1 is present. Wave 1 is present. Rest of the waves are absent. Rest of the waves are absent. Waves are not present. So what does it mean? there is some defect after the distal part of the cochlea, of the distal part of the auditory nerve. That is, it is a retrocochlear pathology. So all the maybe your cochlear nucleus or the cochlear nucleus, lateral lemniscus, inferior colliculus, lateral lemniscus, all of them are normal, let us say, but the auditory nerve has got damaged. So it is not able to conduct the sound to the next part, that is the cochlear nucleus. The cochlear nucleus is not getting activated. If it doesn't get activated, the rest of the auditory pathway also will not get activated. So there is a disease which is present after the distal part of the cochlear nerve. So it is indicative of retrocochlear pathology. Wave 1 is present, rest of the waves are absent. Wave 1 is present, rest of the waves are absent, indicating of retrocochlear pathology. Okay, I think I hope I'm clear. Now, third one, increased interpeak latency of wave 1 to wave 5. What did we say? Usually it is 4 milliseconds. Suppose it is coming at 6 milliseconds. This is diagnostic, one of the diagnostic findings of acoustic neuroma. That is, there is passage of the electrical current, but it is passing slowly. The electrical current is passing slowly. So instead of coming at 4 milliseconds, it's coming at 5 or 6 milliseconds. The fifth wave. The first wave is coming at the right time, but the fifth wave is coming a bit late. So there is some conductive pathology. This is one of the diagnostic findings of the pathology is between cochlear nerve and lateral lemniscus. So it's one of the diagnostic findings of acoustic neuroma. Now we said there is something called interaural latency. Interaural latency, suppose of wave 5 at 0.2 milliseconds, of 0.2 milliseconds. So wave 5 is coming in the normal ear, right ear at 4 milliseconds, but in the left ear, which is having the disease, that is acoustic neuroma, it is coming at 4.2 milliseconds. So there is a difference, that is an interaural latency. There is a difference in between the latency of the right ear, which is the normal ear, and the left ear, which is that the latency is increased in the left ear, which is having acoustic neuroma. This is considered the most diagnostic finding in Bera. That is, interaural latency of wave 5 of greater than 2 milliseconds is diagnostic. It is the most diagnostic finding on Bera in acoustic neuroma. It is the most diagnostic finding on Bera in acoustic neuroma. Okay. So what are the uses of Bera? Bera is considered the mother of all audiometric tests. Basically, for everything we depend on Bera. Suppose the patient is not developing, suppose a child is not developing speech properly, there is a speech delay, we are having a doubt that the patient is having some hearing loss, we always depend on Bera. So we go for Bera, directly we go for Bera. Okay, because there is not much time and because we want to confirm the diagnosis. Okay, but suppose it is in a general population kind of setting where you want to screen, then you can use a screening test, that is acoustic reflex, or you can do autoacoustic emissions, OAs. Okay, Bera is used to confirm, remember, it is used to confirm the hearing loss in neonates, infants and mentally retarded patients, because these patients you cannot do any of the subjective tests. You have to go for objective tests also, and now you are getting clearly what is happening to the 7 waves. Okay, and you can say where what is happening, whether there is any interpeak latency, delay in the wave 1, wave 1 is more getting delayed. Like that, you can basically pinpoint where is the problem in the auditory pathway. So this is basically used to confirm the hearing loss in neonates, infants and mentally retarded patients. Also malingerers who have crossed all of them, and now we want to document. Now he is going for a kind of a, let's say he is going for a lawsuit, and now you want to confirm. Now you go for a Bera. Okay, Bera says all the waves are coming at right time. Whatever the patient does, the Bera waves are going to come at the right time, so you can confirm that he is a malingerer. This is basically one of the the most important diagnostic test for acoustic neuroma, and that is one of the NEET PG questions here you can have. If you want to confirm acoustic neuroma in addition to MRI, Bera is considered one of the most diagnostic tests for acoustic neuroma. And because of the waves, by studying the exact site of the lesion, by noting the latency, amplitude of the affected waves, you can find the difference between the cochlear and the retrocochlear type of lesion. That is what we said. What did we say? wave 1 is present, rest of the waves are absent. This is seen in retrocochlear pathology. Wave 1 is delayed, but rest of the waves are normal, seen in cochlear pathology. So you can find there is a difference. You can find out difference between the cochlear and retrocochlear pathology. Cochlear pathology, wave 1 is delayed. Retrocochlear pathology, wave 1 is present, rest of the waves are absent. Okay, like that you can make it. This is a basic for undergraduate level, but basically these audiologists can really go into the depths of this. Okay, noting latency and amplitude to study central auditory disorders. Why? Because we can also test the various parts of the auditory pathway, that is the cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus. All this also we can test. So if there is any problem with the waves in that particular point, we can say, okay, there is a problem in the brainstem, there is a problem in the auditory radiation, there is some problem in the medial geniculate body. Like that also we can help. It can help to study the central auditory disorders. To find the hearing threshold, wave 5 appears 10 decibels above the PTA threshold. Above the PTA threshold. If the PTA threshold is 10, wave 5 will come at 20 decibels. So whenever wave 5 is whichever decibels wave 5 is coming, if you subtract minus 10 to it, you will get the hearing threshold of the patient. Like that we can help to find out the hearing threshold of the patient. Okay, so basically Bera is the mother of all audiometric tests. It is used to confirm the hearing loss. Before we take up the patient for cochlear implant, Bera is a must. You need a Bera that will tell you exactly how much is the hearing loss. Okay, and based on the waves, you can tell where is the problem, whether it's the cochlea or the retrocochlear. So that is also very important when you want to take up the patient for cochlear implant. And to differentiate cochlear, retrocochlear, I said, then it is the most important diagnostic test for confirming acoustic neuroma and to exclude malingerers. Okay, to study central auditory pathway, various, because the waves come at different, each wave is representing a particular part of the auditory pathway, and hearing threshold by subtracting 10 from the wave 5. Okay, wave 5 is the most important in Bera. Okay, thanks for watching. Please do like, comment, share, subscribe if you find the content useful.